Okay, we're going to start right now. This is Health, Chapter 13. It's a short chapter, so this shouldn't take very long. So while my wife watches The Wizard of Oz in the other room, I will talk about the role of health psychology in healthcare settings. Collaborative care, this is something that came to be with the Affordable Care Act. They started talking about collaborative care. And one of the things they wanted to find out, and if you've been to the doctor lately, one of the things that they ask you is whether you have contemplated suicide lately. It's something that they ask everybody. And the reason they ask that is so that they can cover that aspect of the Affordable Care Act. Collaborative care is a cooperative form of healthcare in which physicians, psychologists, and other healthcare providers join forces to improve patient care. So it sounds like they need a psychologist in every clinic, but the reality is they don't have to, as long as they cover the mental health aspect of healthcare. The criteria that people use to recognize and interpret symptoms vary. Attentional focus is a person's characteristic style of monitoring bodily symptoms, emotions, and overall well-being. People with a strong internal focus are more likely to detect symptoms than people with a strong external focus. Individuals who never think about themselves, who ignore symptoms, ignore sores, sores that don't heal, ignore aches and pains. These individuals tend to not go into a doctor until it is too late, or until it's negative things start to happen to them. Sensitizers are people who cope with health problems and other aversive events by closely scanning their bodies and environments for information. Now, those of you who've been around both males and females know that women are better sensitizers than males are. And possibly one of the reasons is because of the women's monthly cycle. They're very much aware of how they feel and what's going on inside their bodies. Men are try to be macho and they ignore these things. Men are more likely to be repressors. They're people who cope with health problems by ignoring or distancing themselves from stressful information. And unfortunately, men are this way. There was an individual, I think I've told you the story, but there was a farmer and he was working in the field and he was fixing he's fixing a piece of machinery, and somehow it collapsed and it stuck him in the leg. Well, he started bleeding like crazy, and so he decided that he needed to finish his field. So what he did, he laid down in the creek to wash it off, and to because the creek was colder water, it kind of slowed it down. Well, he decided he wasn't going to go into the doctor until after he finished working in his field. And of course, by the time he finished working in his field, he had bled out quite a great deal, and his pants were soaked with blood. And of course, he called his wife, and his wife came out, and she said, "What in the world happened to you?" And he told her, and she called him all kinds of an idiot. And then she took him to the doctor. And of course, he'd lost a lot of blood. He almost passed out on the way in. And that's the reason she drove him in, was otherwise he would have driven himself. And of course, the doctor called him all kinds of an idiot as well. But he decided, and he got his wound infected, because creeks are not the cleanest. That's not really clean water in a creek, especially in Montana. This was in Montana. So the goofball had a lot of problems. How a person views a particular illness, they need to identify the illness. They need to figure out what the cause is. This is something, of course, we were trying to figure out with the coronavirus. We had to identify what it was, and initially, or eventually, we figured out, or they figured it out in China, that it was a coronavirus. Coronavirus is called a coronavirus because it has. If you look at the individual structure of the virus, It looks like it has a crown around it. It has like a halo around it. And of course, SARS and no, wait a minute, SARS and MERS were also coronaviruses. There's a walking pneumonia that's a coronavirus. So we've known about coronaviruses for a long time. This one is a mutated form. That's why they refer to it as the novel coronavirus. And of course, they identified it, and thank goodness that they gave it to the rest of the world. Otherwise, we'd have all these people dying, and we wouldn't know exactly what was going on. So you need to identify the problem. You need to figure out what the cause is, and of course, that can be a problem as well. Once upon a time, there was an outbreak of strange diseases that nobody could figure out. It seemed to be infecting It seemed to be infecting gay males in the United States, and we couldn't figure out what was going on. Well, eventually we figured out it was HIV. But it took a while. It took a while to figure it out. So you can imagine how scared people were when they didn't know what was causing HIV and where it was coming from. There were people that were preaching that it was the wrath of God was punishing homosexuals for being gay. So we need to find out the cause. We need to figure out how long this takes. With the coronavirus, this has been extremely important to figure out how long it takes for the initial infection until the person starts showing symptoms. Initially, we weren't exactly sure, and we were thinking, well, as long as we can isolate the people with symptoms, we should be okay. But now we know that a lot of people are asymptomatic. In other words, they don't have any symptoms. And we also know that it takes between 10 and 14 days for you to become sick if you contract the disease. So potentially I could be sick right now. My wife has been to town. I've been pretty much cloistered here in our house. I haven't left here for today's Saturday. It'll be 2 weeks tomorrow. I will have not left the house. And the main reason is because I'm potentially, theoretically, immunocompromised because of my age. I'm over 65 years old. I'm 70. And the fact that I don't have a spleen, which is one of the major parts of your immune system. And also, I had a heart attack 10 years ago. So for all those reasons, theoretically, I am immunocompromised. But if you have ever been around me, you know that I never get sick. I just don't get sick. So the timeline is something that we have to look at. My wife could have brought it back. She went to the store yesterday, I think. She could have brought it back with her, in which case, in 10 days to 2 weeks, I'll be sick. What are the consequences of the disease? What kind of symptoms do you have? And the answer to the coronavirus is people that are immunocompromised tend to get a very serious upper respiratory problem, and it fills their lungs with fluid, and they get pneumonia. They develop pneumonia, and then they have to be put on a ventilator if it's a serious case. And those are the consequences. Other individuals, they don't have hardly any symptoms at all. It seems to have something to do with age. The more immunocompromised you are, the more likely you are to have a very serious effect to the illness. Controllability, in this case, of course, since you guys are in lockdown, a lot of the world is in lockdown right now. Italy, France, Spain. Some countries are opening back up. Japan won't allow people into their country right now because they're trying to keep the coronavirus out. We have more. Let's see. The United States. More people have died in the United States from coronavirus since first person that died was in February. We've had more people die than all the rest of the world put together, as horrible as that is. Is it controllable? In this case, this disease is not controllable. People who are anxious and those who score low on tests of emotional stability tend to report more physical symptoms. Comorbidity is the simultaneous occurrence of two or more physical and or psychological disorders or symptoms. As many as one-third of all hospitalized patients may suffer from a psychological disorder. And of course, that's something that medical doctors rarely look at. They don't look at for a patient's depression or hyperanxiety or antisocial personality disorder or a schizoid personality disorder. They can't diagnose those, so they don't look for them. A large percentage of people in the United States who have depression also have anxiety disorder, or people with anxiety disorder have depression. You can look at it one way or the other. That's known as a comorbidity. They have two problems at the same time. Alcoholics, a lot of alcoholics are also depressed. Prior experience and expectations affect how people interpret symptoms. Since I worked in medicine for 30 years, that my experience tells me when I'm sick, and I usually know what to expect from the problem. Some patients have the tendency to exaggerate expected symptoms while ignoring unexpected symptoms. Rubble in 1972 found that women who were led to believe that their menstrual periods were imminent reported more symptoms than did those who were led to believe that their periods were not due for several more days. Women are more likely than men to report symptoms and to use health services. Women may be exposed to more illnesses because they interact with their children more. They tend to interact with their children more than men do. Women may be more sensitive to their internal bodily symptoms than are men, and I mentioned that before, and a lot of it may have to do with their menstrual cycles. Social factors such as the fragmented nature of healthcare for women may be factors. Most of the problems were discovered and diagnosed in men before they were diagnosed in women. But the reality is that men they have heart disease more. They have most diseases more than women do. And they die more readily from almost all the diseases that they have. Over one-third of men would not go to a doctor immediately, even experiencing chest pain or shortness of breath. I hate to say this, but that's exactly what happened to me. I started having chest pains on one day, and I didn't go to the doctor until the next morning. I didn't really have shortness of breath, but I could feel that something was blocking. Something wasn't quite right, and rather than slowing down, what was I doing? I was cutting grass for the horses. I was harvesting hay for my horses, and instead of stopping and slowing down, I just went ahead with doing what I was doing. I thought it was a muscle problem. Only 32% have been checked for cancer, mostly prostate cancer, in the past year. Prostate cancer is relatively easy to check for. There's two ways to check for prostate cancer. One is to do a test called the PSA, the prostatic specific antigen, and it will tell you if you have the antigen that is identified with prostate cancer. On the other is a digital investigation where they actually take their finger and they stick it up the male's rectum and they palpate the prostate, which is it's right there. It's right beside the rectum. Rectum's in the back and the prostate's right in front of it. So if the prostate is swollen or if there's any other problem, then they can feel that the prostate has a problem. Men are less likely than women to report having unmet medical needs. Gender differences in physician visits vary by age, and so men are a little bit more difficult to deal with than women are. High socioeconomic status people generally report fewer symptoms and better health than do low socioeconomic status people. Tons of different reasons. They get more exercise. They're more likely to eat nutritious foods. So they don't get sick as often as people of low socioeconomic status. As we said before, fat has a lot to do with disease. It has a lot to do with cancers. So if you're poor, then a lot of your food is not very nutritious. It has a lot of fat in it, and that is one of the reasons why poor people have a harder time with their health. When they are sick, however, high socioeconomic status people are more likely to seek health care, and it's mainly because they can afford it, whereas low socioeconomic status people have a difficult time affording it. They have to go to the emergency room because they really don't have any health care unless they're on Medicaid. Low socioeconomic status people are overrepresented among those. Come on. Low socioeconomic status people are overrepresented among those who are hospitalized. They wait longer before seeking treatment, so they have to stay in the hospital for longer. I've got a cat that's laying right beside my my computer, and he's beating the computer with his tail. So we'll see if he does something else. Some cultures encourage a strong reaction to symptoms, while others socialize members to deny pain and keep symptoms to themselves. Lay referral system is an informal network of family, friends, and others who offer their own experiences and advice regarding symptoms. And of course, sometimes it works, and sometimes it doesn't work. Let's just say that sometimes it doesn't work. Seeking timely care when symptoms arise can mean the difference between dying and catching a disease when it is still treatable. The reality is that if you don't catch diabetes in the early stages, then you might potentially be shortening your life. Same way with cancer, certainly. In the beginning, if you have a cancer somewhere, if you can get a hold of it, if you can start treating it when it is still in one place, then potentially they can marshal your immune system to help them knock out the cancer. But if you wait until it has metastasized, once it metastasizes, then the only way that you can really cure the cancer is either with surgery. But then again, you're potentially doing surgery on various areas of your body. But if you can catch it before, of course, you can cut it out. But if later you have to use radiation and chemotherapy in order to knock it out. Delayed behavior is a tendency to avoid seeking medical care. 5 delay stages, the last 3 stages, delay longest for the patients who were more concerned about the cost of treatment. They had little pain and were doubtful that the symptoms could be cured. Illness anxiety disorder, what we used to call hypochondriasis, is a condition of experiencing abnormal anxiety over one's health, often including vague, ambiguous, or imaginary symptoms. Malingering is making believe one is ill to benefit from the sick role behavior. Malingering is a problem in the United States military. So your unit's going out and you're going to be in combat. You don't want to fight. So instead, you show up sick to sick call, pretending that you got a cold or pretending you got a stomach ache or whatever. And that's known as malingering. Chronic fatigue syndrome, or CFS, is a disorder of uncertain causes in which headaches, infections of unknown origins, extreme tiredness, and difficulties with concentration occur. There is no diagnostic test or known treatment for CFS. It is linked to low blood pressure, persistent viral infections, and immune system dysfunctions. In some, it varies over time course and recovery patterns. I have a very good friend who used to teach, I think he's retired now, but he used to teach at the University of Montana. He was an English teacher. and he had chronic fatigue syndrome. This guy, the reason we were such good friends was because we were on the track team together, and he ran the mile and I ran the quarter mile. He was quite the athlete, had been quite the athlete for most of his life. He had a daughter, and both of them suffered from chronic fatigue syndrome. Really kind of odd. They kind of babied her a little bit. And so I always thought that maybe she didn't really have any problem. She just wanted sympathy from her mom and dad or money or whatever. Eventually, she had a baby. And because she has chronic fatigue syndrome, she claimed that she couldn't take care of the baby. So the parents took care of it and they put it up for adoption. And now she doesn't have to, she has no responsibilities, as weird as that sounds. The treatment for chronic fatigue syndrome, cognitive behavioral therapy to increase tolerance of symptoms and modify maladaptive illness beliefs. He has it and she has it. He's been treated with CBT. She refused to go. So she still has problems with chronic fatigue syndrome. Otherwise, she wouldn't have an excuse to get rid of the kid, I guess. You have to use a multifactorial approach to work with this stuff. Adherence is a patient's willingness to follow a prescribed treatment regimen. Nonadherence is a patient's refusal to adhere to or lack of sustained effort in following treatment regimen. And we see this a lot. Somebody will go into IHS. They don't want to deal with their problem, but they go in anyway. The doctor gives them a treatment plan, and they never fill the prescription or whatever. And that's known as non-adherence. The rate of non-adherence is about 1 out of every 4 people that go into the clinic. 20 to 40% of participants in smoking, alcohol, and drug abuse treatment programs continue treatment compliance after 1 year. In other words, 60 to 80% of the people in smoking, alcohol, and drug abuse treatment programs are non-adherent. In other words, they go back to the drugs. 60 to 80%. Obesity treatment program attendance drops after 3 to 4 months. People just don't want. They're lazy and they don't want to do what they have to do in order to be healthy. Patient variables, gender, ethnicity, education, and income are poor predictors of adherence. Just because you're smart, just because you're white, just because you're black, just because you're male or female, doesn't mean that you're going to do what the doctor tells you to do. Having the support of family and friends, being in a good mood, and having optimistic expectations promotes compliance. Providers' display of empathy and confidence also increases compliance. Provider variables, job status, if they're happy with their job, if they have a not overwhelming number of patients in a week, if their communication style is good, then they will tend to have patient adherence. Treatment regimen variables, keeping regimens as simple and short in duration as possible. It was really kind of interesting. I was up in Montana. I messed up my knee, my left knee, and I needed to go in for orthoscopic surgery. I had 3 chunks of meniscus that had to be scraped off, and he trimmed my ACL at the same time. So here I am. I leave the hospital. He gives me no instructions whatsoever. I had no idea what I was supposed to do. I figured, well, I guess I must be cured since he didn't tell me what to do. Well, it turns out that what he actually did when he said he trimmed my ACL, he cut it. He cut it away. I guess it wasn't really attached, but I didn't realize that, and he didn't tell me. And the reason he didn't tell me, and he didn't give me an exercise program, and he didn't tell me I needed to wear a knee brace, was because most of his clients, most of his patients, were were non-compliant. They didn't do what he said anyway. This is up in Montana. or you have farmers that get wounded and they go ahead and they almost bleed to death in order to finish the field. These are the type of people he had been dealing with, and because of that, he had stopped even giving them regimens as to what they needed to do. Tailoring treatment to fit the patient's lifestyle. Of course, that's really what needed to happen. I wanted to be compliant. I wanted my knee to be 100% again, but of course, it never will be because it doesn't. There's no ACL in my left knee. If I step wrong, if I hit if my toe hits the hole and my heel goes down in the hole, my knee actually bends the wrong direction, bends backwards, and that hurts. Simple, understandable instructions. Of course, he is talking to lay people. He's not talking to a fellow physician. Involving family members, friends, and others in the patient's treatment. This is always good. Providing feedback about progress, how they are doing, and how long they will have to stay with whatever regimen he's given them. Factors affecting patient-provider relationships, continuity of care. This is a problem that I've heard over and over again about IHS, is the fact that every time you go in, you see a different doctor. This is not continuity of care. Continuity means you see the same doctor over and over again. He knows your case. He or she knows your case, and they take care. They know you, and they know your environment. They understand all of these different factors. But if you see a new person every time, as people have complained, then you're not really getting continuity of care. How well do they communicate? Some doctors are really bad at communicating. I was working when I was in the service. I was working for a doctor. I was in the lab, of course, and we didn't make a mistake. We everything we did was right, but he didn't like the result, and he came down and he just read us the riot act. So we checked everything, and by golly, we got the same result. So he determined that we must have contaminated the specimen. So he screamed at us, "You need to get another specimen, and you need to tell her that it was your fault." And so we did. We called her back in. We drew the lady's blood. She was a colonel's wife, and he was afraid. He was deathly afraid that she was going to give him, what for? Her husband was the deputy wing commander. Anyway, so we called her in. She was really nice about it. We drew her blood and there was no problem. Spun it down, got even a lower result than before. And he was so mad. He was ready. He said he was going to court martial all of us and send us all to Vietnam. This is during the Vietnam War. This was in Lubbock, Texas. Uh, so, we did everything we could. We checked our equipment, and everything was fine. Our controls were good. Our standards were good. And then, we had no answer for him. It was just a bad result. So he called the lady and he started talking to her. It turned out that she had been on a diet, and it was a water diet. So she was filling her stomach up with water before she ate, and that kept her from eating a lot of food. Well, one of the problems with drinking so much water is that it dilutes out your blood, so it draws sodium out of your system, and if you get too much, if you can draw too much sodium out of your system, you can actually kill yourself if you're not careful by drinking too much water. And in her case, she was drawing a lot of sodium out of her system, and it gave her a low sodium, and that's what the result was. So we were right, and he needed to listen to us. But of course, he didn't. He's a doctor. He's smarter than we are, and he would rather that instead of a patient having a problem, he wanted to blame the laboratory for the patient result. As it turned out, of course, he never came down and apologized. He had threatened to court martial everybody, and he was wrong. But of course, he never came down to apologize. Overall quality of consultation, of course, all of these things are important. Patient-provider communication is the backbone of all medical treatment. 60 to 80% of treatment decisions are based on information that arises from the medical consultation process. And part of the medical consultation process is the x-rays that he takes, the laboratory tests that he draws or does, and other observations by other individuals. A provider's communication style is the most important factor in a patient's satisfaction with his or her doctor. And of course, a lot of doctors are really, really smart people, but they haven't spent their lives talking to people. And because of that, they have relatively poor bedside manner. Not all doctors, of course, but the ones who are able to communicate with their patients usually have a lot more success. A provider's communication skills, including their nonverbal behaviors, is something that the patients are very attuned to. And a lot of people will choose their doctor by who they can get along with, who they can talk to. Patients often leave a consultation dissatisfied because of a lack of information, poor understanding of medical advice, and the perception of being unable to comply with treatment instructions. Too little time and too much to do. That's what doctors complain. And that's one of the reasons why they have some problem, tend to have problems. The more time physicians spend with their patients, the more satisfied their patients are. My wife ran a clinic up in Montana, and she had a doctor who he'd spend 20 minutes with his patients, and he was really good. He was a pediatrician by training, but unfortunately he had to work as a GP. But he was good. He was really good, and he really enjoyed dealing with his patients. One of the reasons he did it is because instead of working with pediatrics, he was working with a lot of geriatrics. He was working with a lot of old people. And he was afraid he would miss something. So he spent a little bit more time with his patients than other doctors do, or did. Physicians may fail to listen to patients or treat them like children or medical school faculty. In other words, sometimes they talk to them as if they're idiots, and sometimes they talk to them as if they have an MD. People are not chosen for medical training on the basis of their social skills. Usually it's because they can pass a test. And the smarter they are, the better studying they are, the more likely that they will be able to get into medical school. The doctor with a really good personality maybe didn't spend enough time preparing for his test or preparing to be a doctor. And that individual doesn't usually make it in medical school. Medical schools place little emphasis on such skills as their social skills. There are no classes in bedside manner. Providers vary in their attitudes about their own role and the patient's role in consultation. Some healthcare providers have negative perceptions of certain patients. They have the same problems that everybody else does. Maybe they don't like old people. Maybe they don't like ugly people. Maybe they don't like poor people. Maybe they don't like black people. Maybe they don't like natives. Maybe they don't like white people. Sexism is very, very real. Most doctors are male, and they do not, maybe they don't have respect for women. They think all women make up their symptoms because they come in so frequently. And so these can be potential problems that doctors have. Mutual participation. Patients today are more assertive, better informed consumers who insist on playing an active role in patient-provider interaction. In other words, they know things because they look it up on the internet. Once upon a time, and that wasn't that long ago, 1993 is when the internet started, but it hasn't been until the 21st century that there has been a lot of really good information on the internet about your symptomology. Now a doctor expects you to come in with some degree of knowledge. And that's a good thing because he can't screw up. If you think you have something that he didn't even think about, then now you're one step ahead of him. Communication skills training is now a fundamental component of medical and nursing education. Active listening skills, they try to teach them active listening skills. Most doctors, I can remember doctors, they would come in to talk to you, and they wouldn't even look at you. They would be writing their notes the whole time because, of course, they have to do their notes afterwards in order to keep your file up. So these guys would be filling out your file before you're even saying anything to them. And actually, they're not listening to you. They think that they already have your problem solved. Communication enhancing interventions for patients. Of course, this is one of the things you have to do. Once upon a time, I went in for surgery, for heart surgery, and I'm not sensitive to opiates or opioids. And I told that to the doctor, and of course, the doctor didn't hear what I said, and lo and behold, he gave me morphine. And of course, it didn't do anything. So here they are, they're about to cut into me, and I'm still awake. And the doctor started palpating my leg, and I said, I can feel that. And he said, What? You're supposed to be asleep. I said, No, I can still feel that. So he had to hit me with a double dose of fentanyl. Fentanyl is a synthetic opioid. It's a synthetic, and it's 100 times stronger than morphine. And here they were giving me a bolus of morphine and fentanyl. Well, the morphine didn't work because I'm not sensitive to it. The fentanyl did. It knocked me out, but it didn't knock me out for the whole surgery. So they had to hit me 3 times with fentanyl in order to do my heart surgery. It was a heart cath. It wasn't really surgery. Well, heart cath is surgery. The internet they didn't cut me open, okay? They just cut into my artery on my leg. The internet is becoming a major vehicle for healthcare. Telemedicine, telehealth is the delivery of medical information and clinical services through interactive audiovisual media. I was reading an article on CNN the other day, and they were talking about telemedicine is going to have to become the new thing because if this coronavirus it continues to be a serious problem, then people aren't going to be able to come into the hospitals anymore. And we're going to need more doctors and physicians that are dealing with patients through the internet. Part of every healthcare provider's training is telemedicine now. In the United States, more than 36 million people are admitted to hospitals yearly, and many experience problems when they are in the hospitals. The need for efficiency has promoted a one-dimensional, depersonalized view of patients. And of course, if you've listened to me speak about patients and things, we don't really, you can't really treat people as people. You have to treat them as your job. And when you do that, it becomes more and more depersonalized. The more personalized you become, the greater the impact if this patient goes south. And of course, that's not good. You don't want somebody dying, and so the whole medical staff, breaks down and starts crying, and nobody can treat another patient. That wouldn't work. That wouldn't be very good at all. So you need a degree of depersonalization just to work there. If you're reading about what's going on with the healthcare providers, with all these people dying of coronavirus, especially in New York City, if they've started doing some things that people don't like, the morgue filled up almost right away. They had to get refrigerated semis to come in to put the bodies in, and they were okay as long as there were shelves inside to put where they put the bodies. But in some cases, they just had to stack them up. This is something that we saw in the military with large casualties. You can't. They can't take up too much room, and you've got to get the job done. So what do? You just stack up the bodies, and that's really kind of it's not very respectful. That I saw on the news that they're starting to bury people who have died from coronavirus in New York. They're starting to bury them in mass graves. They're all in caskets, of course, but they're lining the caskets up. Nobody is claiming the bodies, so what do? I mean, you can't just let them sit there for an extended length of time. You got to do something. And they've had several thousand people die in New York City. That's hard. That's tough. Same thing's happening in Spain. Same thing's happening in France. And there is a depersonalization to it, but I mean it's necessary. In this case, if you want any care at all, then you're going to have to become a little bit more depersonalized. The people that can't are the ones that are not going to be able to continue to work in that setting. Healthcare systems represent all activities whose primary purpose is to promote, restore, or maintain health. That is a statement by the World Health Organization in 2006. In the United States, there is a mix of public and private hospitals. The patient-provider relationship is crucial to the effectiveness of either public or private hospitals. Hospitalization represents a loss of control and depersonalization, as we said before. Of course, this is something that you don't see anymore. Not with the coronavirus. You don't see two doctors and a nurse standing around talking with a patient. They don't have time. A total institution takes control of virtually every aspect of your life. Patients are expected to conform to rules for eating, sleeping, receiving visitors, and making their bodies available for examination and treatment. The biggest problem is that people suffer from being treated as a non-person. And I'm sorry. I mean, when I was working in the hospital and I needed to draw blood in B13, that patient was B13. I'm sorry. It was not Charlie Jones. Of course, I'd have to ask Charlie Jones if that was his name. I'd have to identify him, positively identify him. Usually you do it with the armband if Charlie Jones is unconscious or asleep. Of course, I wouldn't draw anybody's blood who was asleep. I'd wake them up before I drew their blood. But, you'd talk to them about their name, but if they needed a heart panel, and they wouldn't say Charlie Jones needs a heart panel. There might be 3 or 4 Charlie Jones in the hospital. They have to identify them by their identification number and by their room number. So I would go into B13. I would find the guy that's supposed to be in B bed, the second bed, and I would ask him if he's Charlie Jones. Charlie Jones was not the most important aspect of his identification. It was his hospital number. Informational control intervention focuses on the procedures and sensations that accompany medical treatment. Cognitive behavioral intervention, CBT, directs patient attention to positive aspects of a procedure rather than feelings of discomfort. How does the CBT work? They use modeling, they use guided imagery. They teach techniques for pain management and speedy recovery. As far as childbirth is concerned, they teach the Lamaze method, the Lamaze training. Healthcare needs to have changed in rich and poor countries. Healthcare needs have changed in rich and poor countries. The expectation of access to care continues to increase. The demands for measures to protect people from financial cost of poor health. Information on a wide range of topics, issues are sought. Healthcare professionals are doctors, they're nurses, nurse practitioners, and there are physician's assistants. And all these individuals can treat a patient. They are the ones that save lives: physicians, nurse practitioners, and physician's assistants. Global healthcare delivery system, there are 3 different types. There's National Health Service, that's what Canada has, that's what England has, that's what practically everybody has, a National Health Service. There's mandated insurance, that's the Affordable Care Act, and there's a pay-as-you-go care, and that's primarily what we have in the United States, except if you don't have that, you usually get pay-as-you-go if you work someplace and you have health insurance, that's pay-as-you-go. The mandated insurance is Medicare, Medicaid, and Affordable Care Act. There are pluralistic systems, patient-centered healthcare, delivery of healthcare services that are respectful of and responsive to individual patient preferences, needs, and values, and that's usually the pay-as-you-go plan. I have a feeling that because of this coronavirus situation, and we have so many more people hospitalized than we've ever had before, the insurance companies are probably going to have a little bit of problem afterwards. They're probably going to fold. And what we're going to have is an extension of the Affordable Care Act, maybe a Medicare for all situation, because the healthcare has to be provided for everybody. Otherwise, everybody, and potentially a lot of people will die. So we'll have to give them everybody free health care. And of course, that would be the Medicare for all situation. National Health Service, single provider system. This is also known as the beverage system. It's what they started in England. It has been replicated all over the world. In Canada, in most of Europe, has a single provider system. National level or regional, local level. It's usually national level. Healthcare is paid by the federal government. Fees are collected by the federal government. Low cost per capita. There's usually a copay, but that money goes directly to the government, and the government pays the medical facility. Mandated insurance, so that's social insurance, like as I said before, it's like Medicare and Medicaid, and also Affordable Care Act. Compulsory universal coverage through sickness funds paid jointly by employers and employees. And of course, I have that with Diné College. We have an insurance company. It's HMA. Has something to do with Hawaii. Pay-as-you-go care, an individual purchase of health care at time of treatment. And pluralistic systems, a combination of two or more approaches. Usually it's a pay-as-you-go care and maybe a mandated insurance. It has to do with the employer paying, and you pay as well. Your employer pays for your insurance. And then if you need something extra, then you have pay-as-you-go. This came about because during the Clinton administration, Clinton was president from, let me think, 1992 to 2000. And he wanted to go to a universal health or national health care system. And because of that, they were trying to figure out what they would do. The insurance companies were very much against it. Before 1992, most of the health care was dictated by the doctors. So doctors set the fees and whatnot. So they decided, well, the doctors are ripping everybody off. So let's let's let the insurance companies do it. And that's when the HMOs and the PPOs came to be. And of course, they started setting the fees, and of course they were collecting the fees. So the fees kept going up higher and higher and higher. Part of the money went to the doctors, and part of it went to the insurance company. So now instead of just paying one person, the doctor, now we're paying two people. We're paying the insurance company, and we're paying the doctor at the same time. Doctor's not making as much money as he did before, but the insurance companies have become the middleman. And of course, this is not the best system in the world. What do people want from their healthcare providers? They want to be treated with dignity and respect. They want them to listen carefully to their concerns and their questions. They want somebody that's easy to talk to. They want them to take their concerns seriously. They want them to They want them to be willing to spend enough time with them. They want them to show that they truly care about them and their health. They want them to have good medical judgment, of course. They want them to ask good questions to understand the patient's needs. They want them to be updated. They want them to be up to date with what's going on in the medical world. They want them to see them on short notice if needed. Yeah, that's what people are looking for, to be able to get in. Accountable care organization is an organization of healthcare providers that agrees to be accountable for the quality, cost, and overall care of the members. Affordable Care Act, of course, as I've been talking about before, is expected to bring about changes in how the U.S. healthcare is paid for and provided. When they passed the Affordable Care Act, of course, they brought 18 million people who were not insured, had no health care. Now all of a sudden they had affordable health care. The core principles of the Affordable Care Act: individual mandates, affordable coverage, employer requirements, and coverage for preventive health services. This is something that didn't happen before. Now this was mandated. And that is the end. So we are done. Let me turn this thing off. This is the only lecture for this week. So I'll see you next week. Talk to you later. Bye. Stay safe.